Welcome back to our Unclenched podcast. Today we are going to talk to an endocrinologist, Dr. Komal Patil-Sisodia, and she's also my older sister. We will be talking to her about hormones, how they affect your jaw joints, how hormones change our bodies during perimenopause and menopause, and how that can affect our jaw health and more. But before we get started, I need to get caught up with my Alexandra George. So, what's up with you? What's been happening? I want to hear about your life, a patient you've treated recently. Tell me.
Okay, I got you, Priya. Things are good. Everything's going really well. Very, very busy at the office. But a lot of neat things happening and yeah, life is just so good. My husband and I are getting ready to come over to British Columbia, Vancouver, and then we're going to take a little train ride for a little bit and
To
we'll
my
end up.
house.
Yeah, I know, but we're going to be in Vancouver, Canada. So not Washington. And then we're gonna go up into Banff and Lake Louise and all that good stuff. So I'm excited for that.
Yeah, it's
So
really
life's
exciting.
good. I have no complaints, but I'll tell you about a patient that I had just this past week. In fact, on Sunday, I'm meeting him at the office at 7 o'clock in the morning because he has trigeminal neuralgia really bad. And he's been good for quite a few months, but he'll get just a little twinge. He calls them his little twinges, and we figured out that it happens a lot more when he sits down in work. So he got a standing desk and everything, and I'm like, well, if it's brought on when you're sitting down, something's going on with your lower back. And then I checked his legs out, and he has one leg shorter, which we knew of, and we addressed or I talked to him about, but we never really sat down and addressed it because it comes so sporadically for him, and it's mostly when he sits. So figured that all out. But what I'm doing now, since he travels in from Cleveland, I read a study about the SPG block that I do in my office in it, and the study showed that if you give an SPG block for trigeminal neuralgia 7 weeks in a row, then that helps dissipate it. So I think we're on like week 5, and it's
Oh,
quick. I don't want him to like have to take off work for just something that's so quick. So he's going to come in, and I'll meet him there bright and early Sunday morning and do another SPG. But he's doing phenomenal. He's excited. I'm excited, and I can't wait for him to like work on his core. We've been working on his breathing and just try to stabilize his lower back a little bit better. And we have some PTs involved and stuff like that. But he's going to be 100% before he knows it. And he listens to our podcast. So, shout out to Ted from Cleveland. He knows who he is.
so the only thing you've done is SPG blocks, or have you
No,
also?
no,
Oh,
no. He also has a removable orthotic.
oh,
We did
okay,
try
okay.
DTR on him, and
Didn't work.
it wasn't coming around with DTR, but I think the issue is he had one missing tooth, and I
Yes.
needed contact on that tooth. So, and I've done other people with DTR, disclusion time reduction with a missing tooth, but usually it was like maybe the most posterior tooth.
Yeah.
But I said, let's try it just in case it does work. And it we got some results with it, but I needed to fill in the hole of where he was missing the tooth. So then we did the appliance.
Yeah, fair enough,
Yeah.
fair enough.
So, it's nice to have a few things in your pocket that you can pull from and figure it out. So that was really,
Totally.
really, yeah. So
Yeah.
I'm excited for him. It's like a puzzle every time someone comes in and you try to put that puzzle together. How about you, Priya? What's going
Mhm.
on with you?
So, just a few hours ago, I did the first DTR appointment for a patient who flew from Florida to see me. So
Uh-huh.
he flew from far, and, his bite, poor guy. I mean, it's interesting because it's like you see the anatomy of different teeth, and he has the cuspiest and grooviest teeth I've ever seen. I know that sounds weird, but it's like there's extra structure, like, everywhere, and it was making his disclusion time so long. So that was kind of an interesting case. So we did DTR. He is missing 31, so that kind of, and I told him, I said, "This kind of makes the prognosis for DTR a little bit different." But we saw changes in his muscle activity, we lowered his DTs, we balanced his bite as much as we could. Obviously, we can't get it perfect if a tooth is missing, so I'm
Right, right,
curious to
right.
see how he
Yeah.
does, right? Like, I recommended he start there. He's in a lot of pain, like 7 or 8 out of 10 daily pain. So I'm very curious to see how that's gonna turn out. So that just started. So I know we usually talk about, like, success stories, but I think it's also important to, like, talk about where we start, right? So that was
Right,
kind of
right. Right, because we don't get there overnight, and we
yeah.
never claim to get there overnight,
No,
and,
definitely not.
you know, some people respond very quickly, but some people too even take longer than what we really want,
I
but
know.
that's just their body.
I know. It's hard to give a exact timeline, like, you're gonna be better by this time.
Well,
It's
you
very
really can't.
you
You
can't.
and you I give a kind of ballpark, and
Yeah.
I'm like, but it's a big ballpark. I say
Right.
3 to 6 months.
Yeah.
Yeah, and when somebody suffers for years, that's not a long time.
No, it's
Yeah.
not. They're like, "Oh, really? That quick?" I'm like, "That doesn't sound quick," but in their
Yeah.
life, it is. So let's introduce our guest today,
Yeah.
endocrinologist, Dr. Komal Patil-Sisodia. Welcome to the Unclenched podcast, Dr. Patil-Sisodia.
Thank you both so much for having me, Dr. Alex and Dr. Priya. I am excited to
Mhm.
be here and chatting with you today.
Well, I've heard such great, great things about
Yeah.
you. So, why don't we start by talking a little bit about the connection between the hormones, the jaw joint,
Yeah.
and how hormones influence our jaw joints?
Yeah, I would be happy to talk about that, right? So really the two major hormones that will impact the jaw joint are estrogen and relaxin. And estrogen is what builds up your uterine lining. It is responsible for you having your periods and being able to ovulate. But interestingly, in the jaw, the way that estrogen works is it will inhibit a process called chondrogenesis and inhibit degeneration of the jaw when there's enough estrogen around. And it does that by acting on the estrogen receptor. When you lose your estrogen in perimenopause and menopause, that will actually lead to thinning of the cartilage, loss of the bone matrix, degeneration of the joint overall, especially when you have like the mechanical stress that you both see in your practice, where with jaw clenching and bruxism and things like that. Um, Relaxin will increase tissue remodeling and then make the joint more lax, or what I call loosey goosey, right? And
Mhm.
that will in turn also degrade the matrix, right? So interestingly, lack of estrogen degrades the matrix, relaxin degrades the matrix. But in pregnancy, when both are elevated, they almost work together. It's like the relaxin says, hey, estrogen, join my team, and we're both going to degrade the joint together. So while in women who aren't pregnant, estrogen is actually protecting the jaw joint and not degrading it, when it meets relaxin, it's like the two of them go on a spree and they degrade the joint even faster in pregnancy.
Hmm.
And so it's kind of interesting. You see this weird increase in, well, not weird, but you see this increase in TMJ in pregnant women, but then you also see it later in menopause with women losing their estrogen. And they don't really have high relaxin levels then. So it's kind of interesting.
Yeah. Well, I have a lot of people reach out to me on social media asking, like, why they have more pain when they're on their periods. So obviously the hormones are fluctuating when throughout our cycles, our monthly cycles. Can you speak to why people have more pain when they are menstruating?
So that's a great question. I mean, I think part of it is a little bit unanswered in general. For whatever reason, we do know when women are on their periods, it's harder to anesthetize them. Like I will often warn my patients when they're going into the dentist, and I've also experienced this myself, that if you go when you're on your period, it can take a little bit more to numb you. right? And that's just from a pain receptor standpoint. But the interesting thing is that when you look at the whole menstrual cycle, you have your first phase that's called your follicular phase, and that's where your estrogen is rising. It's building up the uterine lining, and it kind of peaks mid-cycle where you ovulate. And then the second phase is called your luteal phase. And in the luteal phase, the estrogen is still kind of high, but it's coming down. But then the relaxin kind of picks up right before you start your period in that mid to late luteal phase. Your period always starts at the start of the next follicular phase. And so it's kind of almost like that cross between the two is like the estrogen is kind of declining, but still there. And then relaxin pops up. And so I think for some people, it gets worse in that week leading up to your period. And then I think the increase pain sensitivity from however these hormones affect your pain receptors make it worse during that first week of your period or those first few days of your period.
Well, let's switch gears and talk a little bit about perimenopausal and menopausal, because that's the point of life where I am right now.
Yes.
How can hormonal changes that might have been a little too much information, so I'm sorry, but
No, not at all.
Never TMI.
We
Never.
need to talk about this as women. We've spent the last 2 decades not talking about it enough.
Right. So how can hormonal changes during this time impact the jaw?
That's a great question. So I think it's a multitude of different things, right? Like the first is going to be that loss of estrogen, right? In the normal state when women aren't pregnant, estrogen is actually very protective of the jaw. So when you lose your estrogen starting in perimenopause and it bottoms out in menopause and you haven't replaced it with hormone therapy, what you see is that jaw joint further degrades, right? And there was a great paper that came out I want to say last year, called the musculoskeletal syndrome of menopause. And it talks about joint laxity, about like the ortho issues. It was written by an orthopedic surgeon, Dr. Vonda Wright. Great paper. And it talks mostly about like all of these joints throughout the rest of your body. The same rationale applies to your jaw, right? Because why would that be unaffected? And so there are a lot of studies that have shown that women will lose the strength of their joints or of their tendons and ligaments. The joints get weaker, they're more prone to osteoarthritis. And then the other thing that happens is women go through something called sarcopenia, where we lose our ability to hold onto muscle mass. So not only are the joints degrading, the muscles that are supporting the joints go away. And when that happens, you are getting a whole new level of weakening that happens, right? One of the most common orthopedic complaints that women see is frozen shoulder. I think probably TMJ is somewhat underestimated in women. One, because we haven't really been screening for it. It's not until Priya started doing this work that I actually started asking my own patients about this and trying to get them to TMJ specialists in my area. So it will, that lack of muscle support will weaken the airway, and then the airway also kind of collapses in on itself, and then the joints are getting weaker. So everything kind of compounds, and I think is why the TMJ disorders are getting worse.
Okay, this is a little bit off, but when you were saying about the muscle tonicity and everything weakening, okay.
Yeah.
Everybody in California, a lot of my patients around here are on the GLP-1s.
Yes.
Okay. So my thing is like, okay, that would be great. I would love to lose 20 pounds. But when they say that you lose muscle mass, and I think the amount is like 7.5% or something you lose when you're on the GLP-1. Now, when that happens too, they don't tell you what kind of muscle.
Yeah.
Like, is it cardiac muscle? Is it skeletal muscle, smooth muscle? I mean,
that's a good question. I don't know about the studies for cardiac muscle, but I do know that you lose. I mean, those medications actually have a cardioprotective effect. So I don't think you're losing cardiac muscle.
Oh, good.
I think it's mostly skeletal muscle. And, I'm an endocrinologist, so I treat diabetes all day long. I'm also obesity medicine board certified. So I treat patients for obesity as well. And really, when we look at the treatment of obesity or diabetes, there are multiple pillars that we're looking at to keep people healthy. healthy, right? We
Mhm.
want them to be focused on lifestyle. So diet, exercise. We want them to be focused on their mindset and stress. So are they finding ways to wind down? Are they getting good sleep at night? And then we add medication on top because you need all of the lifestyle stuff in check first. One of the ways these medications work is they suppress your appetite and they make you feel full faster, right? And
Right.
if you don't have good dietary habits in place, like you're not hitting your protein goals, you're going to see more
Mhm.
muscle loss than anything else, right? Because let's be honest, if I have a plate of a chicken breast or a plate of chocolate chip cookies, I know I'm going to grab I mean, come on, right? It's like that's human nature. So,
I'm gonna eat the chicken.
of course you are.
I don't even like sweet stuff, but I'm
No,
a weird.
she doesn't. She doesn't. But if it was like, what is a snacky food that you like, Priya, that's carb based?
French fries.
Okay, so if it's a plate of French fries or a
Yeah,
plate of chicken breast, what are you going to grab?
French fries.
Right.
Done.
It's human
Done.
nature to want to,
Sure.
especially when your appetite is suppressed, eat the thing that you want to eat that is more appetizing as opposed to the thing that you should eat to maintain your muscle mass, right? So a lot of our time spent in our clinics is to really talk to people about making sure they're hitting their protein goals. And I'm sure my patients are sick to death of this, but it is like protein, 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 and it is hard to eat the amount of protein you probably
Mhm.
need to hold on to your muscle mass. For women in like peri and postmenopause, it's 80 to 100 grams of protein per day. That's
Yeah,
really
That's a
that's
lot of protein.
it is
yeah.
it's a lot of protein, right? And it's hard because like how much chicken breast can you choke down, right? And then for my patients who are vegetarian or vegan, it's a whole other challenge.
Yeah,
Sure.
yeah.
Yeah.
Wow. Well, have you noticed that your patients have more headaches or more pain during perimenopause and menopause? Because
Yes.
I've seen that, but not like across the board necessarily.
Yeah, I would say so. We do this scale to assess perimenopause symptoms, and it's called the Green Climacteric Scale. And it's 21 questions that they rank from like 0 to 3 points, depending on whether you have no, mild, moderate, or severe symptoms, right? A lot of times women will mark headaches on that. And I looked up the data on this, and it's estimated that 40 to 60% of women in perimenopause and menopause have headaches. They generally tend to be this like aggravated tension type headache.
Yeah.
Um, More so than anything. But I do have some patients who have like menstrual migraines or menopause induced migraines because of the fluctuating hormones, right? So I think it takes some time to really dissect that. But whenever I see that as a complaint, I make sure that I'm trying to address that with my patients.
Well, how we were talking about the relaxin and the estrogen and how pregnancy, how would it impact both sleep and TMJ problems? And
Yeah.
it's weird because sometimes I've had patients do better during pregnancy, and I just always thought that's because the relaxin's in there and it's lubing up the joints, getting ready for you to deliver a baby. And
Yeah.
I just have really less
I've seen
complaints a
that
lot
too.
of times. Yeah, and so, like, I've even told patients too,
Yeah.
wait until after your pregnancy, ones that were like, "I'm feeling good now." I'm like, "Okay, then wait,"
Yeah.
and
Yeah.
we'll start after your pregnancy. I mean, am I wrong? Like, thinking kind of the opposite of what you're
But
saying.
Yeah.
I've seen both. I've seen people get worse during pregnancy. That happened once, but mostly I've seen people like maintain or get better.
Yeah, it's interesting. I have seen, and again, I think we're all skewed by what we see in our practice, right? I have
Mhm.
a fair number of patients with Ehlers-Danlos, and they all get worse in pregnancy, right? I have I've seen kind of a plus and a minus effect to it, right? Like I think I would say that in pregnancy, I don't have a great explanation for why some women feel better versus worse, right? I think a lot
Right.
of it comes down to the amount of weight gain you may have during your pregnancy. Some women don't gain a ton of weight. Some people do gain a lot more weight than they're supposed to. Some people are right on target, but it's kind of what your body can withhold, right? And if you have that pregnancy weight gain, it can really cause issues with your airway and increase that risk of obstructive sleep apnea, right? We see that in obesity in my patients with type 2 diabetes. I think it's estimated that 83% of people have sleep apnea, right? So that weight gain, I would think
That's
would
high.
make it, yeah, it
Wow.
is, right? I
Wow.
would think that it would I would think that the pregnancy weight would make it worse in terms of a sleep apnea perspective. But
Sure.
in terms of like how, because from what I've learned from Priya, the sleep apnea can then worsen the TMJ, right?
Yeah,
Yeah.
absolutely.
So I would think that just everything would get worse in those patients. I don't know that I've ever seen anybody feel better during that time, but that might just be my practice.
Well, what percentage of your patients complain about like TMJ symptoms, like headaches, jaw pain,
Oh,
neck pain, ear pain? Or is
yeah.
it something you pick up on as they're telling you their various symptoms?
Yeah, I would say that since I started talking to you about it, I probably do a better job of screening for it. And I would say probably about 20% is that I'll see it in. When I went and looked up the data, it's estimated 20 to 30%. So apparently I have to do a little bit better job of screening now. Just to make sure I'm capturing everybody. But I will say I've learned a lot from just you, from the how atypical the symptoms can be, right? And I think that this is the thing for women. Our symptoms are never typical, right? Even when you look at heart disease in women compared to men, the presentation in a woman is so different than how heart disease can present in a man. And so
Totally.
I think we just have all these nuances. So my hope is that with better education for doctors that are out there who don't have the level of knowledge that you two do, hearing this podcast lets them think, okay, gosh, I need to start asking these questions and I need to start screening. Like one of my friends and colleagues who's a primary care physician in my system, she's like, who do I send to for TMJ? I sent her all of Priya's YouTube videos and I was like, if your patients are willing to drive to Vancouver, it's a 3-hour drive, go see my sister. Um,
Yeah.
so I think people are becoming more aware of it, but it was a little higher than I anticipated. But I
Sure.
also hadn't been screening before.
Sure.
So in my practice, I utilize, and you probably hear it if you listen to this podcast a lot, the SPG block for
Yeah.
this, palatin ganglion. And many patients always comment on how their anxiety and their headaches decrease. In fact, like one of my assistants at the office, I give her one frequently for anxiety.
Yeah.
And the ganglion is responsible. I try to explain it to the patients like it's the computer system for your body, and we're kind of rebooting it. And it's responsible for the autonomic nervous system, digestion, blood pressure, fight or flight. Can you explain how the endocrine connection with the autonomic nervous system, how that
Yes,
is?
I can.
Dang,
And
Alex, that's a hard
it,
question.
it's a hard question, but it's a good
Thank
question.
you. But I need to know because, I
We
just
all do.
asked your computer system. Next.
I love it.
I
Next.
love it. I love questions like this. I'm also an endocrine nerd, so this is like my
There you
jam,
go.
right? But the autonomic nervous system is so interesting, and it is so intrinsically tied to what's happening in your endocrine system, right? So it is affecting your adrenal glands, your thyroid gland, your gonadal glands, right? So whether you're a woman, your ovaries, man, testes, or person with ovaries, person with testes, however you want to say it. But it affects each of those different hormone productions, and with the adrenal glands in particular, your adrenal glands are making your cortisol, which is your stress hormones, right? So when your autonomic nervous system is activated, your cortisol levels go up pretty
Right.
significantly, right? And cortisol is a survival hormone. It's going to raise your blood pressure, it's going to raise your blood sugar. It's basically trying to get you to outrun that bear that was chasing you, or that saber-toothed tiger that was chasing you
Here.
down the road, right? So it wants you to survive that before you rest. But when it's elevated all the time, that's when I start to see increased risk of high blood pressure, diabetes, high cholesterol. All of the metabolic distortion starts kind of happening with that. The adrenal gland is also responsible for producing hormones that are called catecholamines, which are your fight or flight hormones. So when
Okay.
the adrenals are activated, those surge as well, right? And all of that can contribute to inflammation in the body as well. When you're so activated and it's activated from pain or from whatever it is that is happening, it kind of snowballs from there, right? And when your body is chronically stressed out, what happens then is that the other endocrine axes will shut down, right? I always say that Mother Nature does not want you to reproduce or be hypermetabolic when you're actively stressed or sick, right? So, for example, how it affects the reproductive axis. We all, Summer Olympics come along. I love watching gymnastics, right? Like
Mhm.
watching all of those women do incredible things is like one of my favorite sports. But there are studies that show women who are in that type of intense training leading up to the Olympics, these women gymnasts will lose their menstrual cycles because they
Yeah.
stop ovulating and stop cycling. And so, that degree of physical stress on your body is not compatible with being healthy enough to reproduce at that point, right? So it kind of automatically tamps down when you're overdoing it with physical activity. With your thyroid, for example, when people are acutely sick and in the hospital, one of the patterns of tests that we see is that your thyroid hormone levels will start to drop depending on how sick you get. And then as you recover, they come back up to normal. And it's because when thyroid hormone is working normally, it is a catabolic hormone, meaning it's breaking things down. But you don't want to be hypermetabolic when you're sick and trying to heal from something, because that's also a catabolic state. So the thyroid stuff calms down so that you can preserve your energy stores and recover from that illness. And then it will come right back up and normalize. So it does it in a few different ways and affecting a few different organs. So complicated, but very relevant to, I think, how people may feel relief when you're doing that SPG block.
Mm-hmm.
Yeah.
Mm-hmm.
Yeah. Thank you.
Yeah.
Good
Yeah,
answer.
that was a good answer. Are there any supplements or vitamins that you think everyone should take, or
Yeah.
something we're not getting enough of on a daily basis that can help with inflammation?
Yeah, I feel like that could be a whole other podcast episode, because sadly the American diet is lacking in a lot of things. But I would say that the first and foremost thing that I look at is vitamin D deficiency, because there is a lot of literature out there showing how severe vitamin D deficiency affects bone health. And then I think also specific to TMJ, there is data showing that severe vitamin D deficiency can worsen TMJ symptoms, right? The other supplements that are out there, there's some data, but not as robust as what you see with vitamin D, and that would be like omega-3 fatty acids,
Mhm.
glucosamine, calcium, magnesium, phosphorus. And the calcium, magnesium, phosphorus, I think like any postmenopausal woman should probably be taking for bone health in general. So I don't know that they've done enough robust studies to say it's a definitive thing, but I don't think it can hurt.
Mhm.
So those are kind of the things that I will recommend to my patients who are trying to get their jaw health under better control.
So, and I always say too with vitamin D, because now we're like sunscreen up the gazoo. Even when we're
Yeah,
outside, you're putting sunscreen on. So, are you even really getting vitamin D?
I don't think
But
they are.
what's going on with the body with the vitamin D? Like, how's the vitamin D affect because of the increased TMJ symptoms? Like, how's that happen?
I'm not sure about what the exact mechanism is. I treat
Mhm.
osteoporosis in my practice, so I can talk a little bit about how it does that, right? Vitamin D is responsible for helping calcium integrate into the bone matrix, and it keeps your bones healthy and strong if you have your vitamin D levels optimized. I imagine it's similar in the jaw, but I don't know what the specific mechanism of
That
action
makes
is.
sense.
Yeah.
So I got another question.
Yeah.
We see a lot of women in our practice,
Mhm.
probably more women than men. I know in my practice, but so we talked about like the relaxin and
Yeah.
the estrogen. Is there something hormonal going on with men? With their testosterone, or
Mhm.
is there
Yeah.
something with that endocrine wise that we can talk about?
So I think that's a great question. I think that men also go through what we know as andropause, but it happens much later in life for them, right?
Andropause?
Andropause, yeah, right?
And the men all pause
Yeah, the
with their
androgens
andropause.
pause, right? The testosterone is on pause. And it's interesting, like we see testosterone, low testosterone, right, which is hypogonadism, is
Mhm.
the official name for it. And it can either be because of primary testicular failure, meaning your testes stop producing testosterone, or it can be secondary, where you have like a tumor or a growth in your pituitary gland in your brain that then disrupts the signal to the testes for them to produce testosterone, right? I have seen people develop low testosterone from either of those reasons. I've also seen it in male patients who struggle with obesity, right? Are when you are struggling with overweight or obesity, that is putting stress on your body, and that actually tamps down your reproductive axis. What we've seen is that when men go and lose weight, their testosterone may naturally rise back up to normal.
Oh,
So,
wow.
so you want to find what the fixable cause is first. Like, is it a
Mhm.
pituitary tumor? Is it that you've gained weight? The other places that I've seen it is like people who have chronic pain and who are on opiates. It will downregulate your reproductive axis as well. So men get low testosterone when they're chronically having to take opiate pain medication as well. So there's a few different things that can do that. Generally, though, for the average healthy male who's never had any of those things, testosterone levels don't decline until much later in life. The other area where I will see this is like my prostate cancer patients who have to go on like androgen deprivation therapy, and they have to take those Lupron shots or whatever other shots they are to basically reduce their testosterone levels. I see a lot more bone joint issues there. They actually have all of the symptoms of menopause that women do, right? Which is including collapse of their pelvic floor, which is really interesting. I was talking to a pelvic PT, and she was telling me how in all areas of medicine except for pelvic health, women are underrepresented. But in pelvic health issues, men, especially those who are having prostate cancer issues and on that androgen deprivation therapy, they can actually benefit from pelvic floor therapy just as much as postmenopausal. I
Interesting.
thought it was super fascinating, especially,
Yeah.
yeah, because you always talk about like pelvic floor to jaw
Yeah. Yeah, yeah,
issues.
yeah.
And so I wonder if like some of that may
Oh.
be something that you see in your patients, especially the older patients who have prostate cancer and may be coming in with TMJ. I don't know if you guys have seen a correlation for that.
You know what? Actually, I have, but
Oh, okay.
it's kind of like you kind of feel weird talking to a man about his
No.
pelvic floor.
Fair. Especially when you're in the
No.
dentist's office. I
Right,
I
yeah.
right.
know,
Like, I
like,
mean,
as
I'm
a
I'm
You're
pretty
like, "Wait, what?"
comfortable with my patients,
Yeah.
but sometimes, like, there's like, "Okay, Alex, don't go there because whatever you're gonna say is probably gonna be the wrong thing." So, I just kinda went, "Oh, okay.
Yeah.
Okay."
Yeah.
You know?
Yeah.
oh, interesting. I didn't even think of that. Well, yeah, well, thank you so much for being here with us.
Oh,
This was
Oh my
thank you. It
god.
was great.
It
Thanks for taking the time. We know you're busy to chat with us.
Oh, it was my
no.
pleasure. I've been really looking forward to doing this since Priya reached out to me, and I love the
Obviously, because you
podcast.
get to hang out with me.
Avi, Avi.
Oh my god.
You're such a stinker. I love
Aw.
you.
I do wanna take a moment to let our viewers know
Yeah.
that my sisters and I are starting our own podcast. It's called, You Should Call My Sister,
Yes.
and the date that it's gonna be released has been delayed multiple times, but
Because
it
of
will be
how
there
busy we
someday.
are, but yeah, we'll get
I
there.
know, I know, but
And what's it called again? What did you say it was? It's
You Should Call My Sister.
You Should Call My Sister.
Yeah, and
I think
then
that's lovely. I
thank
can't wait.
you. Yeah, and then my older sister has her own podcast already. It's called Reset Recharge. So do
Yes.
you wanna tell viewers about that and how they can find
Yeah.
you?
Yeah, I would be happy to. So, my podcast that I started April of last year, so it's been over a year now that I've been doing it. I know it's kind of crazy actually when you think about it. It's called Reset Recharge. I started it primarily because it was actually a little selfish. Like I was like, I am going through perimenopause and I need to figure this out because I'm an endocrinologist, and then it can also help my patients and whoever else wants to listen to it. So I've been kind of talking about different topics that come up for perimenopausal women, things that they need to understand about different symptoms they may be experiencing. I've had a variety of different specialists. Priya was kind enough to come on my podcast as well and talk about like the TMJ menopause connection. So, my entire goal with that is just to put out good quality information for any woman that maybe be able to be helped for that, right? And then with my background of endocrinology, obesity medicine, and I'm a menopause certified practitioner, I started my own micro practice called Eastside Menopause and Metabolism. I'm located in Redmond, Washington, and my goal is to help women who are struggling with metabolic disease
Oh, wow.
navigate perimenopause and menopause, because like we talked about earlier, like I don't know if I talked about this earlier, but chronic illness, when you start losing your hormones, starts rising exponentially. And depending on what you have in your genetics, like if you have a strong history of heart disease or diabetes, or those things will start to manifest in you as your hormone levels drop. So where can we intervene? Where can we prevent? Where can we give supplemental therapy to prevent any bad outcomes from that? So that's kind of what my practice is focused on. And, happy to help any women in the state of Washington or anybody who wants to come travel to Washington.
Wow, that's great.
Yeah.
One thing I just have to add something else too.
Yeah.
So when I was going through the menopause
Mm-hmm.
and
The
I was,
menopause.
yeah, the big old
The
menopause,
menopause.
I was getting hot flashes and cold flashes.
Yeah.
Killing me at night, killing me. So I go to the doctor and her name's Karen, and she's like, Alex, how you doing? I'm like, well, Karen, I'm getting these hot flashes, but nobody ever told me about these cold flashes that come along or can come along. She goes, oh yeah, they're awful. And she says, here, let me give you an anti-anxiety med.
No.
Yeah, hold on, sister, to take care of this. I said, but I don't have anxiety. And she said, well, it gets to the same, it's off label, gets to the same area of the brain, and it will help you out. And I'm like, you know what? You hold that thought, Karen. So I go to my office that same day. I give myself an SPG block.
Oh, no.
Now,
Funny.
next night, I only had two hot flashes, or that night I only had two hot flashes because it was on a Thursday. Go back to my office, give myself another block on Friday. 6 months, no hot or cold flashes.
Wow.
Then they came back.
Yes.
Not with a vengeance, but they came back.
Yeah.
Go back to the office, another SPG block. Done.
It makes sense because the thermoregulatory zone in your brain is affected by menopause and the loss of hormones. So that's interesting. I'll have to look that pathway up and
Yeah, I'm telling you. You
Yeah.
can have a little secret recipe in your office.
Seriously, for the people who have hormones and don't want to take drugs.
Yeah.
Yeah.
That's really interesting.
You should write a paper on that. Seriously.
You're like, no.
I know. I'm not joking.
I don't think so. I would know the first thing about writing a paper anyway.
I always tell Dr. Alex that she reminds me of you.
Oh, I love that. That's such
she's so very sweet. Like nurturing and very like sweet. So I was just like, I just gravitated towards her because I was like, oh,
I appreciate that.
Now
I know. Now I can.
I know. Yeah.
Together.
Oh, you've met all the sisters now.
Yeah, I have. I think it's great. I have two sisters too.
Oh, do you really? Oh, I love that. Where are you in the birth order?
I'm the baby.
Oh, okay.
And I always remind you of that.
Oh,
that's great.
Yeah. Okay, so how can people reach you?
So they can find me via my website, eastsidmm.com. So that stands for Eastside Menopause and Metabolism. They can also type in eastsidemenopause.com. I think it redirects to my site. You can find me on Instagram or TikTok. My handle is at Dr. Patil-Sisodia, no hyphens, no spaces or anything weird in there. And I am, I'm around. I love helping women navigate this era of their lives and hoping to make a big impact that way.
Oh, awesome. Well, I'm sure you are. Thanks again for being here.
Oh,
it's so nice to meet you.
My pleasure. It was so lovely to meet you. Thank you again.